Our next speaker is Dr. Yatin Dholakia, who will be speaking to us on tuberculosis, the current trends. May I request Dr. Deepa Paranjpe? Dr. Deepa Paranjpe will be presenting a bouquet to Dr. Dholakia. A few words about Dr. Yatin Dholakia, who is a physician for chest diseases, TB, and HIV/AIDS. There is a Chinese proverb which says, the unconcerned doctor treats actual symptoms. The caring doctor attends to the impending illness, but the superior concerned doctor actually prevents all sickness. We have today in our midst a truly superior and concerned physician, and he is none other than Dr. Yatin Dholakia. Dr. Dholakia is the faculty member of the Wokhard Harvard AIDS Research Foundation and the Director, Inter-Aid Development India, as well as Director, Universal Care Initiative for Tuberculosis Control. Because of his dedication, he has been chosen as the Honorary Secretary and Technical Advisor to the Maharashtra State Anti-TB Association. Dr. Dholakia is a consultant at many places like the Larsen and Toubro Limited, the Avert Society, the Ramakrishna Mission Hospital, the Mahavir Hospital, the Holy Family Hospital, the BCJ Hospital, Santa Cruz, etc., etc. Friends, it is believed that in the 19th century, man has lost his fear of God, but has acquired a fear of microbes. Dr. Dholakia has been eliminating this fear clinically and with research, and has published and presented a number of papers and articles nationally and internationally. Friends, please welcome physician of chest diseases, TB and HIV/AIDS, Dr. Yatin Dholakia. Dr. Dholakia.
Thank you for the kind introduction. And at the outset, I would like to thank the Mr. Swami Narendra Maharaj for having given me the opportunity to speak on this subject. When he gave me this subject, tuberculosis, current trends, I spent sleepless nights. I went through nearly 200 literature papers to make this presentation, and I hope, and looking at the diverse faculty present over here, we have specialists from all fields of medicine, we have private practitioners, general practitioners, and I hope to make this presentation as informative as possible. What I would wish, and being the 150th birth anniversary celebrating year for Swami Vivekananda, I believe firmly that they alone live who live for others. The rest are more dead than alive. Yeah, can I have the next slide, please? Why is TB so challenging? We all know that an infectious disease is dependent on the triad, the host, parasite, and the environment. But beyond the host, parasite, and environment, we have many other factors. We have the socio-cultural factors, the behavioral factors, and then we have the healthcare system, where we have the public health system and the private non-qualified. You can see the jumble of interaction which is happening. I'm trying to see how to make this maze more simpler. Next slide. In my presentation, this is the overview of my presentation. I can give you only an overview of everything. I cannot satisfy everyone's desires over here to go into the different aspects in detail. We'll talk about the burden of tuberculosis, both global and Indian. The thing is that the socio-cultural and behavioral epidemics, the TB, HIV correlation, the TB diabetes, and TB tobacco smoking are the upcoming epidemics of the remaining years in this decade. We have the TB in healthcare settings, which is very important for us to take care. Then let us not wish away this TB and private health sector also. Then we'll come into the more technical topics of diagnosis, treatment, and vaccines and others. The next slide. The global epidemiology of tuberculosis, as of 2010, we had an estimated 8.8 million incident cases of tuberculosis, and 1.1 million among these were amongst HIV-infected individuals. There were 1.1 million deaths in HIV-negative cases of tuberculosis, and an additional 0.35 million deaths amongst HIV positives. Although we have, I think I should. Although we have these dreaded figures, it is consoling to note that the incident rate, that is the cases per 100,000 population, has been falling by 1.3% per year since 2002 globally. Next slide. This is the global picture which shows us that the incidence rates of 2010, mostly in the Africa and the Asian regions, and we have some in the South American region also. India stands at 100 to 299 cases per 100,000. The current figure is around 170 odd per 100,000 population. The dark shadows over here, the dark green over here, indicate that the sub-Saharan region of the Africa is the incidence is very high, mainly because of the TB HIV co-infection. Next slide. India is the largest TB burdened country in the world. We account for about 1/5. That's 21% of all TB incident cases are contributed by India, and we stand 17th amongst the 22 high burden countries in terms of the TB incidence rates. By population, we are the largest number of TB cases in the world so far. Next slide. As I was mentioning, we need to look at the global trends. Now, TB epidemiology cannot be assessed over annually, or it can never be assessed over 5 years or 10 years. As the famous epidemiologist Grzyboski has mentioned, that TB epidemic has to be assessed over centuries. TB is an age-old disease, and whatever ups and downs we see maybe are due to some local phenomenon occurring. But for our pacification, we can see the figures from 1990 to 2010. The incidence rate of tuberculosis has been globally falling, and you can see the HIV incidence gradually rising and plateauing by 2010. And we have heartening news in a couple of days back that the HIV incidence in India is falling. So hopefully this curve will go down. As far as the mortality is concerned, because of the strong commitment by the public health, we have seen that the mortality rates are dropping dramatically. And if we continue the same way, and if we just tackle the other co-epidemics, I hope that we achieve the dotted line over here. This same figures are for the Southeast Asia region and for India as well. Next slide. The global trends in TB case notification. These are depicted in black. As you see that the notification rates are increasing, the program gets strengthened. Then the more and more number of patients come under treatment, and therefore the pool of infection reduces and reduces the estimated TB incidence rates that is seen in green. When I talk about the private sector, there is a movement from the Government of India, Ministry of Health, that TB be declared as a notifiable disease, so that all patients who come to private practice will be notified to the public health, and they will be given the standard TB treatment, and hopefully the pool of infection goes down, and we will achieve the near control of tuberculosis. Next slide. Complicating the TB epidemic is the multi-drug resistant tuberculosis. Can we have this light switched off so that there is not much I think some of the globally the incidence of multi-drug resistant tuberculosis in new cases is 3.6%. 3.6% of all new cases of tuberculosis are 3.6%. There are 27 high burden countries having multi-drug resistant tuberculosis, and 3 amongst them, India, China and Russia, contribute to nearly 60%. India and China alone contribute 50% of the global number of incident multi-drug resistant tuberculosis cases. You can see the various other countries enlisted over here which contribute to the multi-drug resistant cases. Next slide. This is the global map which shows that India in purple. Of course, these striations mention that these are the results of a sub-nationals data only, because we cannot cover. India is a large country which is difficult to do surveillance all over the place, but these are sub-national figures. But India is in the purple range. We have 0 to 3% of all new cases of tuberculosis having multi-drug resistant tuberculosis. Right? You see the Russian Federation, Eastern Europe, contributes to around 12%. China is 3 to 6%. So even China has a very large burden of multi-drug resistant tuberculosis. The next slide. This slide shows us the proportion of MDR cases in previously treated tuberculosis cases. And again, we have 12 to 30% of our population who have been exposed to TB drugs in the past, having been detected as multi-drug resistant tuberculosis. Yeah, there is one section which shows more than 50% over here in the Eastern Europe. Next slide. MDR TB in India, due to the paucity of laboratory facilities which are accredited and doing drug resistance studies, we have very scattered information, but the WHO Global Report on TB, MDR TB Surveillance 2007 has reported 3.4% of MDR in new TB cases, and those patients who were previously treated around 25%. There are certain sites in India like Raichur, we have 2.5%, and in new cases, and surprisingly in previously treated 100%. Paramsivan and all, Paramsivan has been the director of Tuberculosis Research Center, Chennai, and he has reported 100% multi-drug resistant. I think there must be something wrong over there in that site. In the DOTS Plus site in Gujarat, we had 16.9% of MDR TB in the treated cases. In Mumbai, we have from the Hinduja Hospital, Almeida et al. In 2003. These are, of course, a tertiary care institution where all referred cases attend. So 51% of all cases attending this hospital were found to be MDR cases. And then Chaugule et al. In 1998, of course, these are old figures. Kerala is 11%. Next slide. I have been a part of this study, and I think some of the medical officers from the corporation have been very kind enough to have helped us out in this study. This was done in the Bombay Municipal Corporation areas, where in the urban area, that's in the 4 wards of Mumbai, K East, H East, F South and G South, of the new cases, that means those who have not taken any treatment, we found that the overall multi-drug resistance, that is HR and HREZ, was 17 plus 4. That's nearly 21% of primary drug resistance has been found in Mumbai in new cases. And in failure cases, again, the results are very high. We have around 41 or 39% cases who have been detected as MDR tuberculosis. Next slide. Well, I didn't want to, just this slide I just put in today in the morning because I didn't want to, bring a scare. Of course, this is a skewed slide, and which shows that the number of countries marked in red, at least one case of XDR tuberculosis. Now, XDR tuberculosis is defined as multi-drug resistant tuberculosis, that is resistance to INH and rifampicin, in addition to which there is resistance to one of the injectable aminoglycosides and one of the fluoroquinolones. So at least one case of XDR tuberculosis has been reported in all these countries. In India, we have one XDR TB from 66 MDR cases reported from Chennai, And in Hinduja Hospital, the KGMU Lucknow and the AIMS Delhi have shown XDR tuberculosis have been reported. Again, XDR tuberculosis needs accreditation of the laboratory for doing drug sensitivity testing to second-line drugs, which is lacking in India. Next slide. The other thing which is complicating the tuberculosis epidemic is the mycobacterium other than tuberculosis. Many a times we treat cases of tuberculosis and we see they are not responding. And because of, again, lack of laboratory facilities or lack of whatever we wish to call, we do not identify these mycobacterium other than tuberculosis. And we have seen that the incidence of MOTT infections have been rising steadily from 9.1% per 100,000 population to 22.5 in 2005. In fact, there are around 4 mycobacterium MOTT infections out of the 30. These patients masquerade, they present as drug-resistant tuberculosis, and we keep on treating them with second-line drugs and they do not treat. Whereas there is another set of drugs to which sensitivity testing has to be performed, and if we give the right treatment, we can manage them well. Currently, there are no guidelines on managing mycobacterium other than tuberculosis cases. Some people say that you let them alone, don't treat them. Some people say you treat them extensively for 2 to 3 years, with drugs like amikacin, clarithromycin, trimethoprim, sulfamethoxazole combinations, the various combinations which can be given in these cases. So MOTT is another which complicates tuberculosis. Next slide. The big bugbear, the TB and HIV co-infection. The prevalence of HIV in new TB cases is globally is seen. Fortunately for India, the reported prevalence of HIV in new TB cases is 0 to 4%. This is from the WHO global report, and you can see in the sub-Saharan Africa, it's more than 50. And next slide. This is a sort of a meta-analysis which I tried to do from the studies reported in various journals from India. In Mumbai from 1989 to 1999, the seroprevalence of HIV amongst TB cases ranged from 2.3 to 23% cases. New Delhi is 0.4 to 1.14%. This was the time where the epicenter of the HIV was in Bombay and in the southern states, and of course in the northeastern states. Right? Chennai was 1.7 to 17%. Now this is a 4-state study which has been recently reported, 2005 to 2007, shows a figure of 4 to 6% of HIV seroprevalence in tuberculosis in India. Next slide. This was HIV seroprevalence in tuberculosis cases. What about tuberculosis in HIV cases? The lifetime risk of developing tuberculosis in uninfected, HIV non-infected individuals is 10%. As once a person gets infected with HIV, his lifetime risk increases to around 60%. What we have found at the Sir J.J. Hospital, Arcon, where I was a research consultant, is that once the person develops tuberculosis after having acquired HIV infection, his progression to AIDS and death is hastened, and his death, 50% of the people die within 1 to 1.5 years time. So that is the risk of tuberculosis. The other observation that we made was the patients who developed tuberculosis after acquiring HIV died faster than patients who had tuberculosis earlier than acquired HIV later. So these are the observations which are published in the natural history of tuberculosis in the NMJI. Next slide. So by 2010, 350,000 people have died of HIV-related tuberculosis in India, which makes TB responsible for 1 in 4 AIDS deaths. Again, in the study at Sir J.J. Hospital, 73% of all AIDS deaths were due to tuberculosis, and mostly these were of the disseminated tuberculosis type. Again, this reiterates the point: people living with HIV have an estimated 20 to 30% times greater risk of developing active tuberculosis. Again, we all know that the highest risk rates of co-infection are in Africa, the sub-Saharan part, where 44% of TB patients are HIV positive. Next slide. The clinical issues which we need to understand, there are guidelines now formulated for managing TB HIV issues. Screening for HIV in all TB patients has to occur in all adult TB patients. Then this gives us an opportunity, if they are negative, opportunity for prevention of HIV, treatment and improving the quality of life. If they are found positive, then it gives an opportunity to treat and improving the quality of life and reduce the mortality. All HIV patients should be subjected to frequent periodic TB screening. This, if the patient is not suffering from tuberculosis, then it gives us an opportunity to institute TB preventive therapy, isoniazid preventive therapy. And when we are thinking of starting ART, if TB is ruled out, then the problem of iris, that's the immune reconstitution inflammatory syndrome, is negated. Again, if it is identified that they are suffering from tuberculosis, it helps us in managing them, improving the quality of life, and again reducing mortality. We all know that diagnosis is challenging for tuberculosis in cases who are HIV infected, because most of them have atypical presentation. We need newer tests, as we will discuss later on. As far as the treatment is concerned in TB, in HIV infected individuals, the treatment is same duration. We give 6 months treatment for all cases of TB HIV. However, there is a debate whether to give 9 months treatment, which would sometimes reduce relapse rates. Now, the other thing which we need to understand is that now the recommendation says that all HIV patients with TB should start antiretroviral therapy irrespective of the CD4 count as soon as they tolerate TB medicines. That would reduce the relapse rates as well as reduce the mortality and improve the quality of life. Again, infection control in healthcare settings, community and home have to be taken care of in cases where HIV patients are being treated. Next slide. This is the upcoming epidemic. Next slide. Diabetes is associated with a 3.11-fold increased risk of tuberculosis. The higher increases in risk were seen amongst younger people and in populations where the TB incidence is very high, and in non-North American population. This is from the global literature. Diabetes associated with TB increases the risk of failure of TB treatment and for death. The relative risk ratio of 1.69. And again, diabetes, if not controlled, then the risk of relapse is very high. You can see that the risk of relapse is 3.89. And therefore, there is the need to institute, to first of all, to identify people who have diabetes and screen all TB patients for diabetes and all diabetic patients for tuberculosis, just as we do it for HIV. In India, around 50% of the TB patients have diabetes. Right? This has been a report as recent as 2009. And the public health people who are working with the corporation will know that recently there is a drive to identify diabetes and treat them effectively going on in all the municipal hospitals. So diabetes is a substantial contributor to the current and future global burden of TB. Next slide. Smoking is another epidemic which is fueling the TB epidemic. Next slide. It substantially increases the risk of tuberculosis and death from TB. More than 20% of global TB incidents may be attributable to smoking. Controlling the tobacco epidemic will help control TB epidemic. Smoking is a risk factor, independent of alcohol use and the socio-economic factors. It increases the risk of TB by more than 2.5 times. Right? There's a WHO monograph on TB and tobacco available on the WHO website. Part of this presentation is downloaded from there. Next slide. So If smoking trends continued along the current trajectories, there will be an increase in number of tuberculosis cases by 7% and tuberculosis related deaths by 66%. We need to have aggressive tobacco control, achieving a 1% decrease in smoking prevalence per year down to eradication, which would avert 27 million smoking attributable deaths from tuberculosis by 2050. However, in certain high burden countries, high tobacco use countries, if the prevalence of smoking increase at the rate at which it is increasing, 50% of the adults are getting addicted to tobacco smoke. 34 million additional deaths from tuberculosis would occur by 2050. So there's an urgent need to manage this smoking epidemic also to avert catastrophe. HIV will be in the back seat and TB smoking and TB diabetes will come ahead. Next slide. Smoking and TB death rates are double among smokers versus non-smokers. 1/3 are due to respiratory diseases, chiefly tuberculosis. 1/3 of the deaths among smokers is due to vascular diseases, and 11% among cancers, mainly of the respiratory and the upper GI tract. So currently smoking causes around 700 deaths per year in India, chiefly from respiratory or vascular disease. So there is an urgent need to control the smoking epidemic as well. Next slide. So whenever a patient comes to us in a clinic, we have to use these 5 R's. The relevance to ensure that TB patients know their treatment will be more effective if they quit smoking. Risks, to point out all the risks of continuing to smoke, including the risk of TB relapse. Rewards of quitting smoking on effective TB control. Roadblocks, ask the patients to identify any obstacles to quitting smoking. And repetition, we have to continue to encourage patients to quit smoking. So these are the 5 R's which have been advocated as a WHO quit tobacco smoking strategy. Next slide. TB in healthcare settings. This is the one which concerns us all. There have been reports of doctors, especially postgraduate medical students, dying of MDR tuberculosis, even in the city like Mumbai. And this is taken from the Emerging Infectious Diseases as late as 2011. TB in healthcare workers, we are all healthcare workers, where the TB burden is intermediate, like in ours. We have 91 healthcare workers as against 82 in the general population. There has been a report from the LRS Institute, New Delhi, where the incidence of tuberculosis amongst all staff was 790, whereas the national incidence of tuberculosis is, as I mentioned, 170, 182, maximum 220. So it is 4 times the risk of tuberculosis in TB in healthcare settings. The introduction of TB transmission control measures, and I cannot go into the details of all this. These are administrative measures, there are engineering measures, there are policy measures which need to be instituted, would decrease the TB annual incidence amongst healthcare workers by as much as 50% to 81% in high incidence TB settings. Next slide. TB and private health sector. We always receive brickbats, and these are 2 international publications where this was way back in 1998. Tuberculosis patients and practitioners in private clinics. There was a study which was conducted by Indians, of course, and in the slums in Mumbai, where 100 private practitioners were asked about their treatment practices, and 78 different regimens were being followed for tuberculosis, for treatment of tuberculosis. 20 years down the line, there comes another publication from one of the authors is same, the other authors have changed. Tuberculosis management by private practitioners in Mumbai, India. Has anything changed in 2 decades? And the paper says that nothing has changed. I think we should awake and do something about this. I have a personal publication. This is in relation to MDR tuberculosis, which is in print in one of the Indian journals, and which says that consultants, private practitioners, are following the national guidelines. So this paper is to counteract these two papers. I hope it will have some impact on the global views. Next slide. And therefore, the World Health Organization and many other international agencies have developed these guidelines, the international standards for TB care, where there are these guidelines for diagnosis, guidelines for treatment, and I'm sure that you are all members of the Indian Medical Association. Next slide, please. And the Indian Medical Association has taken up this project. This is a global fund project to advocate the international standards of TB care, and this is being implemented all over the country. The IMA has also taken up the PPM initiative. They have formed IMPACT, which is a consortium of all medical associations. We have the IMA, the API, the Indian Association of Pediatricians, and there's the Indian Association of Pathologists, and many other professional bodies have joined into this and have partnered in the public health initiative. And RNTCP has developed public-private partnership guidelines with incentives to participating doctors. So these are the things which are going on in the current areas. Next slide. Now coming to diagnosis. Diagnosis of tuberculosis has been changing. There is a growing shift. As we know that in olden days, there were only, where no x-rays were there, the diagnoses were only through symptoms. You know, tuberculosis was known as consumption, so if patients had cough and loss of weight, he would be suspected of having tuberculosis, and then, of course, there was no treatment at that time. When x-rays came in, we used x-rays as a diagnosis, and then there was this sputum examination, and histopathology examinations were being done. Now we have the culture on solid media, and culture on liquid media is the newer methods. Then we have the drug susceptibility testing being performed, and the latest technology is being used is the molecular probes, which are used for the diagnosis of tuberculosis. Next slide. This is the new diagnostics development. We'll dwell on it for a little longer. There are 3 levels of care. This is at the point of entry care, right, where the patients first approach a health setup. Then there is this intermediate level, and then there is this referral level. It's a tertiary care institution. You can see the red are technologies that have been available, and then they are endorsed by the World Health Organization and even the National TB program. The technologies in blue are in the late stages of development. There have already been clinical trials on these technologies, and the ones in green are technologies are in the early stage of development. We see on the right side the accessibility to these technologies once they are available for the public should be 95% at the peripheral level, 70% at the intermediate level, and 10 to 40% at the. So some of the technologies which are already available are the new these sputum smear examination for diagnosis of pulmonary tuberculosis. Then we have the improvement on the microscopy. We had the monocular microscope, then we had the binocular microscope, then we have the fluorescent microscope, and now what is known as the light emitting diode microscopy will be slowly phasing out the older technologies and will be available at the peripheral laboratories so that the same day diagnosis can be given. Then one of the very good new technologies is the expert MTB RIF. This technology, of course, it's very expensive. The machinery is very expensive, but gives you a diagnosis of tuberculosis as well as MDR tuberculosis within 2 hours of the patient coming to you. So the patient sample is collected, is fed into the machine, and within 2 hours after the patient has coffee and breakfast, comes back to you, and he'll have a diagnosis, TB, no TB, and if there is TB, whether it is multi-drug resistant or not. Then the other diagnostic tests were the liquid cultures, the rapid speciation methods, then the line probe assay. Again, it's a very fast technology. Of course, the drawback, it is used only in sputum positive cases. Line probe assay gives you a diagnosis of MDR tuberculosis in 3 to 4 days time. Then we have the non-commercial culture and DST levels like the MODS, the NPA, that is the night, and the isotope levels. The nucleic acid amplification tests are under development. Right? So these tests are yet to come. Right? So these are the new diagnostics development. Then there are certain recommendations. Next slide. Recommendations upheld by the World Health Organization and the Indian Revised National Tuberculosis Programs. They say that serological tests like the TB, IgG, IgM and IgA have no role to play in TB diagnosis. IGRAs, that is the interferon gamma release assays, the quantiferon gold or the TB gold, although they are better than the tuberculin skin test, that's a Mantoux test, it is not suited for high endemic situation countries like ours. It can be used to diagnose only the latent TB infection. There's a new terminology that latent TB infection, those patients who are infected but not suffering from tuberculosis are labeled as LTBI. This is more relevant in the West where the endemicity is not that much. ESR and TST have no role in diagnosis or assessing the progress of disease. There is studies which say that IGRAS has some role to play in assessing the progress of disease. But the gold standard would be again culture sensitivity and smear examination. Next slide. Coming to the newer treatments. Next slide. The available TB drugs have been regrouped. I hope we can read this. Group 1 is the first line drugs, ionized rifampicin, ethambutol, pyrazinamide and rifabutin is classified as group 1. Group 2 are the injectable agents, aminoglycosides. Group 3 are the fluoroquinolones, moxi, levo and ofloxacin. Group 4 are the second line oral bacteriostatic drugs like ethionamide, prothionamide, cycloserine, teridazole and para-aminosalicylic acid. And group 5 are the agents which are still under experimentation, agents which unclear efficacy and not recommended but still being used by us, all of us. We have clofazimine, linezolid, amoxicillin, clavulinate, thiacetozone, imipenem and high doses of isoniazid and clarithromycin. So these are the 5 groups of drugs for tuberculosis. Next slide. This gives you the total history right from 1946 where the first drug streptomycin was identified. If you see, there was a long gap between this point and this point. Right? The rifampicin was in 1963 and in 1980 ofloxacin was discovered as an anti-TB activities. So there was a long gap. Then the gap again increased, but then there are these shorter gaps. So the drug discovery development is occurring very rapidly. There are certain drugs which are being in pipeline. Then there are the strategies. If you see, then these were these single drug strategy, then you had the combination, then you had a 1 and 1.5 year treatment, then rifampicin came in that shortened the treatment duration and streptomycin was replaced with pyrazinamide, and now we have shorter drugs, shorter duration of treatment with the availability of fluoroquinolones. Next slide. I hope you can read this slide, but it's very busy. 10 compounds are being studied at clinical development, 4 from the existing drugs, and there are 6 new chemical compounds are being studied. Fluoroquinolones are being studied in clinical studies to assess whether they would be able to shorten the treatment duration. Nitroimidazoles, 2 are in the development stage. We have the P824 to shorten the TB treatment duration, and the other one is being tried for MDR tuberculosis. Diarylquinolone is TMC 207, has been shown to be effective in converting sputum early, especially in MDR TB cases. Then we have rifampicins. Rifapentin is being reconsidered to shorten the treatment duration for tuberculosis. Oxazolidinones are like linezolid, is used off-label in MDR-TB treatment, but however, long-term use has a lot of cumulative toxicity. Another analog, this PMU 100480, is being developed and is being tried in combinations to reduce the treatment duration for tuberculosis. Ethylene diamine is again a derivative of ethambutol, SQ109, is under development. Challenges which are faced in new drug development, a formulation of drug combinations. Although we have so many drugs, they have to be tried in different combinations so that achieve early sputum conversion, good cure rates, and very little relapse and prevention of MDR and XDR tuberculosis. So these are the challenges for the new drug development. Next slide. And lastly, the WHO guidelines has become very simplified. All new cases should be treated with 4 drugs in the initial 2 months and 2 drugs in the next continuation phase. And all previously treated tuberculosis cases, or before the start of treatment, culture and drug sensitivity testing should be done for at least isoniazid and rifampicin. So these guidelines have been very clear cut. If the patient has taken treatment in the past, subjected to DST, culture and DST, and treat accordingly, and all new cases with this drug. Next slide. And lastly, I would like to touch upon what is happening in the field of vaccine development. There are 3 places where vaccines can be given. One is the pre-exposure, like the BCG vaccine. There are new vaccines. BCG itself is being studied in its various different recombinant forms. M. tuberculosis recombinant heat-killed and live vaccine is also being studied for a pre-exposure vaccine. There are in different stages of development. Post-exposure vaccines to target dormant Mycobacterium tuberculosis and preventing reactivation of latent TB infections. These vaccines will be helpful in preventing activation, especially amongst HIV infected individuals. And then this vaccine, therapeutic vaccine, is in the clinical phase 2 trial. MVAC is being given to shorten the treatment duration, time to sputum conversion, and improve cure rates in NXDR tuberculosis. And RUTI is another vaccine which is being tried. So there's a lot of developments occurring on the TB field. TB is an age-old disease, and I think we need to tackle it because of the 3 looming epidemics. And next slide. Next slide. What I didn't touch upon is what is happening also in the TB field is a lot of ACSM activities, that is advocacy, communication, and social mobilization activities. And these are the things which are to be instituted at the earliest. So if we all have a public health approach, the private sector, the diagnostic labs for private sector, and the community at large work together, then we would be achieving our goals in time. Thank you for patience listening.
Thank you, Dr. Dholakia, for your informative session and the update on TB. Thank you very much. May I request Narendra Maharaj to present? To present a book, a memento and some books to Dr. Dholakia.